Hello and welcome to the Dementia Doctor. What if I told you that there is a kind of dementia which does not present with memory loss? What if the personality changes that you're noticing in your loved one could be a sign of dementia? I'm talking about the behavioral variant of frontotemporal dementia. Let's go back in time in 1848 when a railroad worker was going about his day with rock splitting and helping with the railroad construction. With an unfortunate accident, there was an explosion and an iron rod went straight through his head, through the left cheek, into the eye, and up in the left part of the brain. As you can imagine, it took him a while to recover from that injury, and he also developed brain infection, and a part of his brain had to be removed. But what his friends noticed that he and his personality changed significantly to the point that he was not really the same person that the family and friends used to know. He used to be a very gentle, well-mannered individual, and after this accident and his brain injury, he turned out to be someone who was rude and did not really pay attention to social cues and was not the same person as he used to be, the gentle, loving human being. This was to the extent that he even lost his job. So let's kind of talk about this term frontotemporal dementia itself. So I have a model of the brain to kind of explain what is happening in this disease. So in this disease, the primary part of the brain that is affected is the frontal region, very appropriately named because it's in the front of the brain, and also the temporal regions. So those regions of the brain that are under the temporal bone, these parts of the brain, the temporal regions as well as the frontal regions, are the most commonly affected regions in the brain, and hence the name frontotemporal dementia. And today we're going to talk about the most fascinating type of frontotemporal dementia that is called as the behavioral variant of frontotemporal dementia. This is quite a mouthful, but we already talked about the term frontotemporal, and when we say behavioral variant, we are indicating that the primary issue that is going on is behavior and personality changes. Let's talk about all the features that we notice in behavioral variant of frontotemporal dementia. We typically use an acronym to help us remember these symptoms, and that's how we teach this syndrome in medical school as well. So we use the acronym, very simple to remember, ABCDE2. Now, A here stands for apathy, B stands for behavioral disinhibition, C stands for compulsions, D stands for dietary changes, E stands for empathy loss, and the second E stands for executive function issues. So let's talk about them one by one. So the first symptom that we're going to talk about is apathy, and this can manifest as apathy or inertia. So what do we mean by that? Is just having an indifference to the activities that are going around the patient and a lack of interest in participating in day-to-day activity, or even a lack of interest to change what you're doing. And this could manifest, for example, families will say, my loved one is sitting in front of the television and he or she does not even want to change the channel. They're just sitting there and the TV is on. Or they are sitting at the dining table for hours at length without doing anything. So that's the inertia part of it. In terms of apathy, it could manifest as motor apathy, so not wanting to do activities that need you to move about. It could manifest as cognitive apathy, so not wanting to do things that involve your cognition and thinking, as well as emotional apathy, so just that lack of engagement and motivation that is seen normally is lacking in this condition. Now coming to B, which stands for behavioral disinhibition, this is the most interesting feature of behavioral variant of frontotemporal dementia. And this kind of goes back to what we were talking about Phineas Gage, because this affected a part of the brain that causes disinhibition or lack of social decorums or lack of social functioning that we learn over time. So this could manifest as socially inappropriate behavior. An example of that would be excessive familiarity with strangers or children that you do not know. Individuals with behavioral variant of frontotemporal dementia are known to touch individuals that they do not know or engage in conversations with excessive familiarity, which might make other individuals uncomfortable. This could also manifest as getting into someone's physical space or hugging people that they don't even know. So we talked about the socially inappropriate behaviors. Another way that it can manifest, the disinhibition can manifest, is with having loss of socially learned behaviors or loss of social decorum. An example for this would be eating out of someone else's plate without their permission in a restaurant, or just a lack of those social learned graces. For example, we tend to be very mellow and quiet at funerals, but an individual who has frontotemporal dementia may be found to be cracking a joke at a funeral, which is very inappropriate. The third way this inhibition can manifest itself is doing reckless, rash, impulsive decisions. So this could be something like changing lanes without checking. This could be something like giving your bank details or social security number to strangers with just being friendly and telling them these are my details. Coming on to C, which stands for compulsions. Now these could be motor compulsions, so these could be simple motor tasks or simple motor repetitions that the individual does. It could be complex motor compulsions, and it could be even verbal or speech compulsions, or stereotypies is how we characterize it in medical terminology. So an example of a simple motor compulsion could be just kind of tracing a circle over and over, rubbing your body over and over, scratching parts of your body over and over. That could be considered as a simple motor compulsion. When we talk about complex motor compulsion, that could involve saying a prayer every time you see a specific kind of vehicle, or it could involve tracing a very specific path every time you walk outside your house. Something that is more complex in terms of motor function could be considered as a motor compulsion, something that this individual just needs to do every day, every time, in the same specific order and way of doing it. Now, speech stereotypy or a speech repetition can be seen when some individuals are just seen to have a very specific phrase that they start repeating over and over. For example, your loved one who meets anyone starts saying, "You are a wonder to the world," or any kind of other phrase that they keep repeating over and over. D stands for dietary changes, and dietary changes again can manifest in 3 different ways. The first one is a change in your dietary preferences. So this is a very drastic change, and an example that I often give my families is that my loved one always had coffee without a coffee creamer, and suddenly at the age of 62 or 63, they're just adding a lot of creamer in the coffee, which is highly unusual of them. So some changes in your dietary preferences wherein you really never liked some kind of foods, and then you started liking certain kinds of food or avoiding certain kinds of food, which is very specific and very rigid. That's when we start calling it as a altered preference that is frequently seen in behavioral variant of frontotemporal dementia. The second way the change in dietary preferences can present themselves is with having excessive binge eating kind of behavior. So if you think about it, binge eating disorders are fairly common in society, but they typically occur in individuals who are younger. It's highly unusual for a 60-year-old to suddenly develop a binge eating disorder. So if there is a lot of binge eating and also carbohydrate craving and excessively eating cakes and sweets one after the other, that is one of the features of behavioral variant of frontotemporal dementia. Now, under the dietary changes also comes these addictive behaviors. which involve excessive cigarette smoking or excessive alcohol, which is a big change from baseline for an individual. Last but not the least, we are coming to our 2 E's. Now, the first E is standing for empathy. So lack of social empathy or lack of sympathy is also a feature of frontotemporal dementia. In this, what family members will say is that there is lack of interest in social activities which the individual previously had, and there is this coldness to the personality. So the examples I often give my family to elicit this history is, what if they saw you crying? What would be your loved one's response? Would they respond appropriately, or would they not respond appropriately? And another ways that this can present is with situations, for instance, someone fell down and an individual with behavioral variant of frontotemporal dementia would say, instead of asking if they're okay, they would say, come on, get up, or they would not even pay heed to that. So that lack of personal warmth and empathy as well as sympathy also is affected in this disease. And now talking about the last E in our acronym, that is executive function. So this is the CEO of the brain, or the executive of the brain. It sits right in the front of the brain, and which we were talking about, the frontal lobe of the brain, and this decides how to plan, how to do multitasking, how to do problem solving, how to divide my attention over multiple tasks and make sure all of them are safely completed, and also having to do with attention. So that's the executive function that is also affected in frontotemporal dementia. That is why we said that in this disorder, memory is usually not affected. It's more this planning, decision-making, problem solving, attention. That's the primary cognitive function or cognitive domain that is affected by behavioral variant of frontotemporal dementia. Now, while I have this model of the brain, I would like to show you where exactly all these behavioral features live, because that is really, really interesting. So before starting, I would want you to have an orientation of this brain. So this brain is, imagine that this is what, if you remove my skull, this is what the brain will look from the front, this is what it looks from the side, and this is what it looks from the underside. And so let's start talking about behavioral variant of frontotemporal dementia, which primarily affects the right side of the brain. And we will talk about the symptoms again with our acronym ABCDE2, and we'll talk about which parts of the brain are affected to cause those symptoms. And we'll talk about apathy first, or lack of motivation or inertia. To see what part of the brain is affected for that, I actually have to split open the brain to show you that region, so bear with me. So as you remember, this is the right half of the brain, and I said it's the inner part of the brain. This is the frontal lobe. All of this is the frontal lobe here. And when the medial or the inside part of the frontal lobe is affected, that's when you have apathy, lack of motivation, you have inertia as well. Moving on to behavioral disinhibition. So remember the example of Phineas Gage, where he had a drastic change in his behavior, he lost social decorum, and he was very rude and inconsiderate to his co-workers and family members. Well, we were talking about a specific part of the brain, and as if you remember, I talked about how that iron rod went through the cheek into the eye, and this part of the brain that's sitting right above my orbits. For orientation to this brain, this is where my eyeballs would be. So this was the part of the brain that was affected, and this part of the brain is called as the orbito because it sits right above the orbitofrontal region. So if the orbitofrontal region is affected by any disease, you can see disinhibition. Coming to compulsions. So compulsions, as we talked about, could be motor compulsions, or they could also be verbal repetitions, and these could be simple as well as complex. So when we look at the brain from the top, all this area from this dark blue region is all frontal lobe, and when this red area, which is called a supplementary motor cortex, when this is affected, you can have repetitive motor behaviors. So when we move and do different kinds of activities, the dark blue part in our brain is the one that actually controls our movements, but right in front of it is what we call as the supplementary motor cortex, which is also closely involved in movements. When this area is affected, this is what causes compulsions, the motor compulsions in frontotemporal dementia. Interestingly, the obsession part of these compulsions is also controlled by the temporal lobe, and that's not on the right side, but on the left side. So our temporal lobe has folds, and it has three folds called a superior, middle, and inferior temporal gyrus on the left side. And when the lower two, called the middle and the inferior temporal gyrus, are affected by this disease, we can see these obsessions that I have to do this thing this way, otherwise something wrong will happen, or this is how I will do this over and over repetitively. So coming on to dietary changes. Now, dietary changes are also a little bit a combination of the lack of inhibition, which was where we talked about the orbitofrontal region, which is sitting right on the top of your orbits of the eyes, as well as there is a region called as insula. So if I split open, this is the frontal lobe and this is the temporal lobe. If I split open these two, there is a deeper part of our brain called as insular cortex. And when these regions, including the orbitofrontal cortex as well as the insular cortex deep in the part of the brain, are affected, there is this kind of compulsive binge eating and changes in the dietary preferences. So coming on to E. Now, isn't this very exciting, looking at the brain and seeing even where things like empathy or sympathy lives? To me, that's really, really exciting, and that's what brought me to the field. But let's keep going. So the empathy for other people, or the ability to recognize what other people are going through and what should be my appropriate response to them, lives right here. It is the right anterior temporal lobe. So this is a temporal lobe on the right side, and there is a pole here. This is where empathy and understanding of other people's emotion and what is an appropriate emotional response to different emotions live. Interestingly, studies have found that in individuals who have autism, there are differences in this region of the brain. Now, last but not the least, the executive function or the cognitive issues that the individuals face, wherein we talked about planning, decision-making, problem-solving, all that lives in the dorsolateral cortex. Again, a very fancy term just to say it lives on the outside lateral surface of the frontal lobe of the brain. This is where all of your planning, decision-making, the executive function or the CEO of the brain lives. So this is very different from the places in brain which are affected by Alzheimer's disease, and you can see why these symptoms are also very different from Alzheimer's disease. So for Alzheimer's disease, the part of the brain that is affected is pretty much very deep in here. It's in the fold of the temporal region. It is called as the hippocampus, the memory center. So that is why frontotemporal dementia and Alzheimer's disease look so different, because they are affecting different parts of the brain. Not only that, the kinds of proteins that cause frontotemporal dementia and Alzheimer's disease are very different. So in Alzheimer's disease, as you may already know, the types of proteins that cause the problems are called as the amyloid protein and the tau protein. As opposed to that, in frontotemporal dementia, the type of proteins that we see that cause the disease are the tau protein, TDP43 protein, or the FUS-related protein. Now, because these are different kinds of proteins, they do have some preferences in terms of which part of the brain they will go on and accumulate, and that is how the symptoms are manifested. Very rarely, the Alzheimer's protein, called as amyloid and tau, will go in the front part of the brain and present with very similar kind of features of behavioral variant of frontotemporal dementia. Now, behavioral variant of frontotemporal dementia is commonly seen in individuals who are 65 and younger. So in individuals who are really young, this is one of the very common types of dementia. And when we have an individual where they are in their late 50s or early 60s and the family presents with these kinds of symptoms, we always have to discriminate between if it is caused by Alzheimer's proteins or if it is caused by the proteins that typically cause frontotemporal dementia. Now, in the last part of the talk, I would want to talk about very specific nuances of this disease and also to help you think through how to advocate for your loved one the best. So number one, frontotemporal dementia is one of the most common dementias which are seen in individuals who are younger than 65 years. So anytime I have an individual who comes to the clinic and is complaining of memory and cognitive issues, I often screen them for frontotemporal dementia if they are younger than 65. Number two, as we talked about it, the frontotemporal dementia, especially the behavioral variant, particularly presents with personality changes, not so much thinking or memory issues. Number three, it can be very difficult sometimes to discriminate between frontotemporal, the behavioral variant of frontotemporal dementia, and depression and other mood disorders. So as you can think about it, apathy or this lack of motivation to do things or to participate in social interactions, as well as sometimes even changes in your dietary preferences where you just don't want to eat as much or you're eating excessively, can be the features of depression. And when I feel that I'm getting a history of depression, I go down and ask about all the features of depression, because as we just kind of reviewed, apathy can be seen in depression as well as behavioral variant of frontotemporal dementia. And these are two very different diseases, and the treatment as well as the prognosis is very different. So it's very important to kind of discriminate why is this individual eating in this way, and in terms of apathy, seeing if they also have other features of depression, including hopelessness. And oftentimes when we see individuals with behavioral variant of frontotemporal dementia, they would often say, my mood is great, I am not experiencing hopelessness, or I'm not having any low moods. So that's how it is different from depression. Number four, you may ask, how is frontotemporal dementia diagnosed? So for the diagnosis of frontotemporal dementia, we use the same acronym that we had talked about earlier, the ABC2. Out of these 6 features, we want the individuals to at least have 3 features. And when we have an individual with at least 3 features, as well as the fact that they are noticing these progressive decline in their cognitive functioning, which is over a period of time, not that this person just had one instance of disinhibition or one instance of binge eating, but this is kind of a pattern that you're noticing. When you see that in combination with the 3 out of 6 features that we talked about, that's when we say this individual has possible behavioral variant of frontotemporal dementia. Now, when you have all of that, in addition, you're noticing that now I'm having functional decline. I'm not able to pay my bills. I'm not able to get my groceries. I'm not able to take my medications or drive around. That kind of functional decline, as well as when I take the picture of the brain, the MRI, and I see shrinkage in the frontal regions and the temporal regions, or I do a metabolism scan and I see that this part of the brain, the frontal and the temporal part of the brain, are not really as good with metabolism, or they're not as active, that is when we say it is probable behavioral variant of frontotemporal dementia. Now, how do you get a definitive diagnosis of frontotemporal dementia? Either you have pathology, which basically means you have a biopsy, which typically does not happen when individuals are alive. This is a post-mortem diagnosis, but a way that it can happen in your life that you can get a diagnosis of definitive or definite behavioral variant of frontotemporal dementia is by genetic testing. If you have the certain genes that are associated with this disease, then we can say that, oh, you definitively have this disease if you also have the atrophy or shrinkage in the front part of your brain, in addition to the symptoms that we had earlier talked about. Now, last but not the least, the fifth question that I often get in the clinic is this genetic? So although there are some genes that are associated with frontotemporal dementia, and we can see it to be a familial condition where the behavioral variant of frontotemporal dementia can be seen running in families, but it is less common as compared to when the disease is seen sporadically. So sporadic behavioral variant of frontotemporal dementia is more common than the genetic forms of behavioral variant of frontotemporal dementia. So oftentimes when we have families in clinic and when they say that they are having these problems even before the age of 65, we do go into a 3-generation family history. So we do talk about their parents as well as their grandparents and screen if anyone in the family had similar features before the age of 65. So hopefully this video was helpful, not only thinking about the different personality changes, but also having a brain model to visualize what parts of the brain are affected in the behavioral variant of frontotemporal dementia and how it is very different from Alzheimer's disease or the image of dementia that you typically imagine. In the next few videos, we will continue talking about frontotemporal dementia, but at this time, we will talk about the language variant of frontotemporal dementia. Till then, take care and goodbye.